Can't hear you.
Morning, everybody. It is indeed an honor to have Dr. Dutt with us. Well, more than our acquaintance, many years back, even before I knew him, I would follow him on the postgraduate training matters, his chapter or his page that he wrote so wonderfully, and I would ardently follow the training programs across the world in minute detail, the step-by-step methods to follow. He would very nicely highlight in this fantastic book called the ENT News. I never knew when I was following him at that time, I would have the unique privilege and distinction and honor to invite him to my department to interact with my postgraduate. My postgraduates are privileged to be interacting with a person of this eminence in the field of cochlear implants. Dr. Dutt has taken it to the next level. Warmly welcome, Dr. Sunil Dutt.
Thank you, sir. Thank you very much. That was a very kind introduction. I'm very humbled, privileged, and honored to be with you, a person of eminence and excellence yourself. I think the feelings are all very mutual. You've been a fantastic teacher all these years. I think I've known you for more than 2.5 decades now, and it's fantastic to be involved in this kind of virtual postgraduate training programs. And I've been doing a few of these now in the last 1 year, thanks to COVID. I think these are some of the very good positive outcomes of a pandemic like this. I think we're open to this possibility in the virtual world of this postgraduate training on the virtual world. So I'm more than happy to answer all your questions, but very briefly, my background is like this. I I did my MBBS from St. John's and then here in Bangalore, and then went on to do postgraduate training, that is MS on the All India seat with Dr. Kirtane in KEM Mumbai. Following my MS, I came back and worked in St. John's for a year or so as a assistant prof, and then to the UK for further training, and that's when I was very interested in learning on about hearing implants in general, cochlear implants in particular. And at that time, this was 1994, 95. Uh, we didn't have training programs here, including Dr. Kirtanes. They were all just beginning to consider it as a intervention, and so that's when I chose to go to the UK on the overseas doctors training scheme, and and that was, you can imagine it, you have to start from scratch. So I had to go through the grind, do all the exams, the FRCSs and whatnot, and then get into a registrar training program in the West Midlands, mostly in the city of Birmingham, and then got the training in cochlear implants, bone anchored hearing aids. The work on bone anchored hearing aids also gave me a PhD in the Netherlands, because we were at that time the largest BAHA program in the world, in Birmingham. Following all that, with options of staying on there or going further west, we chose to come back. My wife and I. My wife's an anesthesiologist. We chose to come back. Briefly worked in Dubai for a year and a half or two. I also did a neurotology clinical fellowship in the University of Toronto under a very eminent figure, Dr. John Rutka, and he has several textbooks and textbook chapters as well. Dr. Devan's quoting one textbook chapter that I have in Scott Brown, but I've learned from all the names or many of the names you probably have seen in your textbooks, and that was indeed a really worthwhile experience for me. I was out of the country for about 10 years, and I've come back, and I worked both in St. John's again, and now I've been in Apollo, uh, the main Apollo in Bangalore for the past 15 years now. Our cochlear implant program, I started the first pediatric program. Dr. Madeva had done a couple of adults in Bangalore. The pediatric program was started by me in St. John's, and we continued that. we crossed over about 500, 550 maybe implants. Dr. Kiri has done a few more than that. And I think together, all of us implant surgeons in Karnataka put together, we have performed about 2,500 to 3,000 implants, including Mangalore, Manipal, and so on, Mysore. But there are many, many, many children waiting to be implanted. The Karnataka government program had a good start, but then they have again uh, kind of shelved it. Hopefully, it'll be soon. And and we don't know about other hearing implants, but then there are other states who've done well, and there is also the national program called the IDIP program, which is supporting cochlear implants. So that's in brief my story and the status of cochlear implants in the country. But then this, I'm told, is a very interactive session. I'm very pleased to see Dr. Ravi Nair is also there. He's my mentor. If he's listening in, I know Dr. Devan had Dr. Ravi Nair speaking to all of you, and my inspiration to pick up ENT was this young, dynamic assistant professor of ENT, Dr. Ravi Nair in St. John's, when I was in the final year of MBBS. Said, if I want to do a surgical specialty, I want to be like him. And that's how I followed Dr. Ravi Nair. Thanks to him and his advice throughout my career, since I've known him from I don't know, 1988 or 87 maybe. He's been absolutely fantastic as a mentor. So, um, so I'm really pleased to see that he's also signed in. I think without further ado, Dr. Devan, will take the questions and let's keep that going. And I would like to introduce Apurva Kumar. Apurva, if you can show your face. He's our chief of audiology. And I took the liberty of including him in the discussion because if there are questions audiology specific or related to ASLP, I would like him to answer some of those questions. And he's also been in this field for about close to 20 years now. So we are happy to answer all your questions now. Go ahead.
Sunil, wonderful of you to bring in your chief audiologist because we have a whole lot of our entire audiology faculty has logged in or would be logging in. Faculties across India have requested a record of this meeting, which I will be recording like others. But
Sure.
before that, how I stumbled onto you is from that fantastic page you wrote on postgraduate training matters. Can you tell us a bit about that? Because it's so nice and so informative, which unfortunately, after you sort of left, it has become defunct.
Yeah. The I think that some of my colleagues in India have known me through ENT News. ENT News started off as a news magazine.
Sorry, have you logged in?
Now it kind of
Have you logged
parallels
in?
any other
Yeah,
channel, I would say, except that it's
there,
not
there,
a peer reviewed
there is
channel.
there's a chief of
So
speech thing. He
so
has
there
also
is
logged. I mean, on the thing. Can you tell others also? Thank you. Thanks.
yeah.
Yeah.
So ENT News, I think for about I've been still with them. I'm still a global ambassador for them. But then I used to manage certain sections of ENT News, which is a publication from Scotland, Pinpoint Scotland in Edinburgh, and I used to manage some reviews for them. And following that, I became the conference news editor. I did some bits on postgraduate training, which is what Dr. Devan is talking about. And then I went on to be a section editor for what's called News Round for several years, even after coming back to India. Then I was chairman of the International Liaison Committee. So we contributed a lot to this news magazine. It's a very good one. It used to be like the Hello magazine of ENT and audiology to begin with, but then instead of binning it, people started putting it up in their libraries, and you can see this magazine really doing very well in the last 25 years. And I think I've served them for more than 25 years now.
Maybe, Dr. Sunil, all your former contributions could be made available as a PDF because it is so nice and detailed, you know. I would wait for the next ENT news to come because your coverage on that was so thorough and meticulous. How did you do that?
Well, I was just hardworking, I guess. I don't know how to answer that. Thanks to the likes of Ravi Nair and Milind Kirtane and David Proops and Richard Irving and John Rutka and all my mentors. I think it's how passionate they were about the subject and the training that made me what I was. So I would write a lot. I would publish a lot, and like I said, Dr. Ravi Nair had given me 2 publications even before I finished internship. As a final year medical student and as an intern, I had 2 publications. One of them was in the JLO. So at that's how it started. And so I got this, I don't know, the knack of writing or something like that, which I think I honed and developed it, and here's where I am. And I think I have about 80 publications in various peer-reviewed journals,
Fabulous.
20
Fabulous.
non-peer-reviewed publications also. I keep to do that too. I can put them all together. I'm sure I'll need some time. No
Yeah,
one.
you know what happened was they had a fantastic ear, nose, throat journal had a fantastic section called Private Practice Builders Corner. I wrote to them, and all the Private Practice Builders Corner articles they sort of bunched it together and sent it to me by courier. It was very kind
Right.
of them to do that. Now, Dr. Sunil, we have stalwarts on this group. We have the head of or the principal of our speech engineering school, Dr. Ravi Nair has come. I see Dr. Deepak has come on, and various other faculties will be logging in. May I therefore straight away go on to the program? We have
Yeah.
11 postgraduates with us. May I call upon Dr. Amrita to sort of formulate your question to Dr. Sunil Dutt, please?
Good morning, sir. This is Amrita. Am I
Morning.
audible, sir?
Yes, very clear.
Amrita, all postgraduates will have to say your name, where you come from, what level of training that you are in, and if Sunil is interested, you'll have to highlight a bit about your thesis, and then go on to your question. May I have your question, Dr. Amrita?
Yes, sir. Sir, I'm Amrita from Mangalore, sir. I'm a third year postgraduate. And my thesis topic is the relationship of the depth of the voice in relationship to the height of an individual. So, my question is, sir, in cochlear implantation, what is the incision that you use, sir?
The incision. See, the incision that we use is a post-oral incision.
Okay.
Now, and there are some surgeons who use the endoral incision as well, and that depends on the approach you're taking. So I would modify your question to not just the incision, but also the approach, right?
Yes.
You're probably also referring to posterior tympanotomy versus the transmeatal approaches, that includes the varia technique. You're
Yes.
probably familiar with the two. So if we are doing a posterior tympanotomy approach, that is doing a cortical mastodectomy and then doing a posterior tympanotomy, the facial recess has the boundaries, the incus bridge, the chorda tympani, this is the right side, and the facial nerve in the fallopian canal. So if we are opening there in the facial recess, that's called a posterior tympanotomy approach. That is best done with a post-oral approach, with a post-oral incision. You can do it with an endoral incision also. Now, most varia technique proponents do it with an endoral incision, because with an endoral incision, you're readily already there in the ear canal and you can lift the TM flap. We don't do that in the posterior tympanotomy approach. We don't lift the TM flap. We leave the external auditory canal untouched. We go through this facial recess and then look at the round window niche and perform a bony cochleostomy or a soft round window cochleostomy and insert the electrode. So it really depends on the approach of the cochleostomy and hence cochlear implantation that will guide us whether it's a post-oral incision or an endoral incision. Now, both techniques can be done with both incisions. So it's how you're trained, how you're teachers taught you, that you will stick to the same technique.
Okay, sir. Thank you, sir.
You're welcome.
Wonderful. May I have Dr. Vidya, please?
Good morning, sir. Myself Vidya. I'm from Udupi. I'm third year postgraduate, and my thesis topic is effect of personality trait on voice, sir. And my question is, when you're doing cochlear implantation, if you come across a cochlear ossification, uh, what you're supposed to do, sir, in that situation?
Yeah, so that's a really long question in my opinion, because the answer to that will be really long. But I'll keep it very brief. Cochlear ossification is something that I should be prepared for so well in advance. It's not while doing the surgery that I suddenly come up with the surprise of a cochlear ossification, that I don't find uh, the lumen of the cochlea. So cochlear ossification would already be noticed in the radiology that we do. In the candidacy criteria, radiology that includes a CT scan and MRI scan would have already told me if there is cochlear ossification. And there is a classification for cochlear ossification. That's called the Tom Balcony classification. So depending on how much is the ossification, how many turns of the cochlea have been ossified, and the commonest ossification is in the cochlear, I mean the basal turn of the cochlea, the scala tympani itself. And then the scala vestibuli can get involved, and then the second turn and the third turn. It can be a complete, what we call a whitewash on a CT, or a complete blackout on a MRI scan where you don't see any fluid signal. So it is something that I'm already prepared. Very rarely, or I don't know of anybody who's suddenly been surprised by a cochlear ossification at the time of surgery. I would have been already mentally prepared. So let's say it's a ossification of the basal turn of the cochlea, and only the scala tympani is involved. Then I would look at the scala vestibular insertion of the basal turn. If that is also not possible, I would go to the second turn of the cochlea. You know where we do the cochleostomy? We do the cochleostomy normally, if not through the round window membrane, we will do an extended round window approach, or we do a bony cochleostomy antero-inferior to the round window membrane. That is the normal cochleostomy approach. But if I don't find a lumen, even after going 5, 6, 7, 8 millimeters, you can go up to 9 millimeters depth. While you're drilling, we use skeeter burrs and keep drilling there. If I've gone right up to 9 millimeters, I think that's roughly the cutoff. I think I've gone deep enough. I'm not finding the lumen. Okay, that's when I look at possibly the scala vestibuli of the basal, which again you would have seen in the radiology whether the scala vestibuli is involved or not of the basal turn. So if it is not, you will be able to open there. If you can't open there also, you're looking at the middle turn cochleostomy. You can do a middle turn cochleostomy just anterior to the stapes, below the processus cochleariformis. You understand me? So you can remove the incus bridge, you can remove the incus also, disarticulate the IS joint, remove the incus, and go anterior to the suprastructure of stapes and below the processus cochleariformis, and you will generally find that you will be able to open up there, and you can then insert what is called a depth gauge or an insertion test device. So you basically, these are dummy electrodes. I don't know if you've done temporal bone dissections, and these companies give you dummy electrodes to insert during temporal bone dissection courses. So a similar sterile electrode, a dummy electrode, is used to see what length of the cochlea is available for insertion or electrode insertion. Once you get that, so you would then open up the electrode length that you're comfortable opening, depending on which company implant that you're using on that day. You will use either a compressed electrode or a shorter electrode than a usual normal length electrode. And that's usually how we do, how we handle ossified cochlea. Okay.
Dr.
sir.
Dutt,
I don't know if we have time with, but there are audiological implications here. Do we have the time to?
yeah, we have.
Yeah.
We have.
So I'll ask Apurva to talk about our series of ossified cochlea. We've done about 15 to 20 maybe.
You're like a Mondini defect.
Mondini is a cochlear malformation where we
Yeah.
talk about ossified cochlea. It's either post-meningitic ossified cochlea or
And then
post-viral.
a bit about the how if you come across a Mondini defect, how you handle them as well.
I will talk about that, but just before that, very quickly about
Yes.
ossified cochlea by Apurva.
Yeah.
Basically, we're looking at in case if we are able to get a lumen, then the other choice would be to use a split array, in which case, if a split array is used, the frequency allocation is also going to be split between the two parts of the electrode array. Now, like how Dr. Sunil mentioned, if the electrode goes in through the middle turn.
1 second, I forget your name.
My name is Apurva Kumar.
Welcome to the group, Apurva Kumar. There's a huge retinue of postgraduates and audiologists across Bangalore who have logged in and seeing you. Thank you very much for your time.
Thank you for that. So like if the middle turn, the electrode's gone through the middle turn, then one of the possibilities could be, it could be an anterograde or a retrograde insertion. That means sometimes the electrode can turn towards the basal turn as well, instead of going towards the apical turn. In which case we reverse the frequency allocation so that to maintain the similar tonotopicity of the cochlea. So these are the audiological considerations which we can make in case if we run into an ossified cochlea and have to choose a different set of electrodes, and post insertion if we see some variations in the ossified cochlear implantation.
Yeah. And you would tailor make the switch on and the mapping depending on
the
what
frequency allocation, we will try and readjust based on the findings.
Yeah. And touching upon what Dr. Devan was asking about cochlear malformations and the commonest wing. So again, there's a huge Levent, Seneroglu, and what's his name? His colleague at Sachi classification. And some of my Indian colleagues, Monish Grover, has modified it. So there are different classifications for cochlear malformations. Mondini is a very popular one and a very common malformation as well. In a Mondini, what happens is there's some arrest embryologically at around 6 or 7 weeks of intrauterine life. And so all the three turns of the cochlea are not available. The second and the apical turn kind of fuse. So there's a cystic malformation of the second and the apical turn, and there's no modulus in that area. So there's half a modulus available, full turn of the basal turn available, but the second and the apical turn are only half. So in that situation, you can expect, not always, you can expect a little bit of a pedalim fleek or a CSF, not gusher, maybe a oozer kind of situation. You'll be prepared for that. And then electrode choice wise also, you need something, and I would prefer something that hugs the available modulus in these patients. So a modular hugging or a perimodular electrode, as they were called, is probably of choice to make sure that you stimulate the available spiral ganglion cells in that modulus, because beyond that there is no modulus available and you may not get any stimulation. So that's the idea of Mondini. Mondini is pretty common because out of 1,000 candidates, you would definitely see about 15, 20, 25 with Mondini, maybe more. I think we've seen a lot more than that. And they do very well, provided you've got a good technique and you used one of these electrodes. So you need a shorter electrode or a perimodular electrode, and these kids do almost as good as those so-called normal cochlears. That's Mondini in short.
Okay, Dr. Sunil, the ossification following meningitis is so grotesque that every child that I see, I advise a meningitis vaccine. But my concern is, have you come across patients who have developed a meningitis in spite of a vaccine?
So what vaccine do you give also matters, right? So we are looking at the commonest, which is pneumococcal. The second common is Haemophilus influenzae in India. we don't have meningococcal meningitis that common in India. So vaccines today, even in the UIP, Haemophilus influenza is definitely covered. Pneumococcus is not so much, I think. Prevnar is not so much, but it is available for, as a choice vaccine, and many parents choose that for their children. So I would say post meningitic deafness and hence ossification of the cochlea is not as common as it used to be in the past. There are several studies on this from Africa for us. Africa also has a rampant meningococcal meningitis possible. So I personally feel vaccines do help. I feel the same about COVID, but that's another topic altogether. But vaccines definitely help, provided you cover the common ones. So Prevnar, which is the pediatric vaccine available for pneumococcus, I think has, I'm not 100% sure, quite a few, about 20 or 22 maybe. You can correct me if I'm wrong there. So a lot, it's a polyvalent vaccine of the pneumococcus. Haemophilus influenza is for, I think, type B. That's good enough. Meningococcal, we don't give. Now, for adults or a little older children, there's a pneumovac vaccine. That's, I think, about six variants that are covered of pneumococcus, 6 types. So I think all vaccines definitely help because you would not get into a meningitis stage and hence post-meningitic ossification stage. Because once post-meningitic ossification sets in, and incidentally, you're talking about all your theses. My thesis for MS with Dr. Kirtane was, you will not believe, and I never got to publish it, was on post-meningitic deafness, localization of site of lesion by brainstem evoked response audiometry. So what we
Oh,
looked at, yeah, it was a fantastic. What we looked at was pyogenic meningitis children, tuberculous meningitis children, and some viral meningitic children. How many of these actually developed hearing loss, and how many of these developed hearing loss of the cochlear or the post cochlear, variety. So in tuberculous meningitis, understandably, there's a basal meningitis. So all their deafness by BERA, by localizing, wave 1, 3, and 5 and whatnot, we could make out that they had a retrocochlear deafness. And all pyogenic meningitis and viral meningitis were of cochlear variety, cochlear deafness. So that was an interesting thesis for those times, 1990 to 1994 that I was with Dr. Kirtane. That's when I did my thesis on that. So I think vaccines definitely help. They prevent the occurrence of meningitis and hence of ossification.
so in this regard, don't you feel that meningitis vaccinations should be part of the pediatric immunization program, which it is not?
That's what I said. Haemophilus influenza is. So HIB is part of the that I think four things that they do, right? OPV, uh,
Yeah.
and the diphtheria, pertussis, and tetanus. I think they've
Yeah.
included Haemophilus influenza in that, but they've not included pneumococcus. And I think
Yes.
you're right. It should be part of the UIP. It should be part of the UIP.
Yes, yes. Now, Dr. Sunil, this whole thing was started by House and Boucher, who's a French guy. Now, the House, of course, went via the electrode, but Boucher said that modulus is the way to go. And as a consequence, he started this 6 millimeter platinum electrode directly into the modulus. Your thoughts on that, please?
Yeah. So, I mean, that's the kind of research that is lacking because nobody bought that. It's not easy to get into the modulus. Let's be honest with that. So it's trauma, and you may damage a lot of those spiral ganglion, residual spiral ganglion cells that these patients have in starting from the modulus and going beyond in the canals, the Rosenthal canal and whatnot. So So the idea today is evolved from preservation, structural preservation, and hence functional preservation of the residual hearing that these patients have, these children have. And that's it's in the very low frequencies towards the apical term, and that bit in the modulus. So if they have some residual hearing, the idea is to try and save that, and that would be kind of defeated if you did a modular electrode or a plate or a wire. Um,
Yes.
it makes sense to realize that. So I think that's probably why researchers abandoned that mode, and more lately. I think we will probably touch upon that later. Is that not just putting in the electrode? You put a soft insertion. You put a atraumatic electrode. All the companies are working on atraumatic electrodes, shorter insertions, not too deep insertions, and probably even drug-eluting electrodes, so that you can you can preserve the neural populations, or even stimulate the neural populations with some growth factors and things like that. So that is probably research that's going on. There's not much money that is spent on hearing research or deafness research, you know that. But that is the way forward. So I think a modular insertion or a through modulus insertion would kind of defeat the purpose, and the kind of tonotopicity that these guys want, the audiologists want, would possibly be better with tapping the osseous spiral laminas, circling around the modulus, right, sir? So that would definitely help in frequency distribution that these guys like, and I think 40 years of research has shown that's the way forward. Multi-channel cochlear implantation.
Yeah. And now 5 implants we have done, of in which we did a 3D reconstruct and found that in 2 of them the cochlea was completely rotated inwards, and it was difficult accessing the round window. Well, how did you tackle these?
Yeah. So that's, again, radiology has improved, tremendously in the last few decades, from what we used to train with to what it is today. So 3D reconstructions, virtual tour of the cochlea, and all that is possible today. So if there is this entity called a rotated cochlea, and I'm also a believer of that. And then so you're looking at various angles and heights and rotations. Uh, that can be a class for another day. But so we look at all this, we sit with the radiologist and understand where exactly would I get the lumen of the scala tympani of the basal turn in relation to the round window membrane. So that is something I've already planned before surgery, and I may need to go. So, like you rightly said, you may not find it just antero inferior to the round window membrane always. The round window membrane itself may be obscured. It may have gone to the roof of the round window niche. It may have gone further posteriorly. And accordingly, the scalar tympani of the basal turn would have moved upward and a little deeper. So you need to go up and find the lumen first. So you will always find it. You may need to lift the TM flap now, like they do in the Varia technique, and see, identify the round window niche very clearly, because if you've got your widest posterior tympanotomy, you may not be still seeing the round window membrane. You may lift the TM flap and look for it. So there are various possibilities to identify the round window membrane, the niche first, and then the membrane, and hence plan a cochleostomy into the scalar tympani.
We had the great tragedy when we were using the skeeter, the drill bit broke and got stuck there. You have ever had such a thing? Fortunately, the neurosurgeons bailed us out. They lent us quickly from the neighboring theater, but such a catastrophe has happened for you?
No, sir. Well, hopefully not. But I've heard a couple of others who've had it. I also know of someone who's had the very tiny bit, I think 0.6 millimeter bit of the skeeter going into the cochlea, and I think it's just lost there. I don't think it's it caused any trouble to the patient, that it probably seals itself off and didn't
So,
trouble.
so in this regard, since it did go into the cochlea, my shock was when Jack Pollack, the editor of the Ear, Nose, Throat Journal, said, cochlea is not the seat of hearing. It is a vestibule, which is why the Teflon piston, when it goes a little inside, you get a dead ear. It shook the audiology, the hearing community. Jack Pollack, editor, said, cochlea is not the seat of hearing, but the vestibule is. Any thoughts on that, Sunil?
Well, they are together for a reason. That's what I feel. There's hearing and balance together for a reason. There's music and dance together for a reason. So it's the creator's mystery. I don't think we've cracked it. Why are they together? I honestly don't know. But the thought that I have is, if you look at the anatomy, look at how they are interconnected. If you look at the membranous labyrinth, that's the cochlear duct, right? The cochlear duct connects with the saccule. So the cochlear duct extends beyond your round window membrane into what's called the cochlear cecum. And then there is that connection between the saccule and the cochlea, called the ductus reunions.
Yes.
Why do we need that? It sounds ridiculous to have something like that. Why do you have to connect hearing with balance at all? So there are all these mysteries. So there's ductus reunions there. And from the saccule to the utricle, you have another utricular duct. And the utricle and the saccule are very close to the foot plate of the stapes within the vestibule in their spherical and elliptical recesses. So they're all interconnected. So disturbing one will disturb the other one too.
Yes.
So yes, you're right. When we have inserted electrodes in the scala vestibuli of the cochlea, so why do you need a scala vestibuli in the cochlea? You know, something that connects to the fenestra vestibuli. So there you go. That's your vestibular connection there. So both the guys, as in the vestibular vestibule and the canals, semicircular canals, and the cochlea, have some representations of the other within them. That with the hearing and this with the balance. So I think if we crack that, if we understand that, that's a research call, and I don't know how you'll go about doing that research. We will understand this better. So I will tell you another story about vestibular implants. Now that you're raising this, vestibular implants, research is going on in 4 or 5 centers at the moment for bilateral vestibular loss of the Meniere's type or ototoxicity type, where they put 3 electrodes in the 3 ampullae of the semicircular canals. And there is a 4th electrode going into the cochlea also, just in case in stimulating the vestibular implant, you knock off the hearing, they want to cover the hearing with that cochlear implant. So they have figured that it is possible that with the vestibular implant, you may knock off the hearing of these patients, or it may already be 50% off. It may go further. And so I think it will come to a stage where, there's some degree of understanding that one and the other are interdependent. We're actually studying vestibular losses in patients with cochlear implants also. There's a lot of research going on, both in the pediatric and adult population. So the short answer to this is we're still looking at it.
Yes. And in 2 of our patients, the semicircular canals were malformed. They were just finger-like processes projecting up. But we were surprised to see they had no balance problems at all. Then why I was wondering, what are semicircular canals we are talking about in balance?
Yeah, I've seen that too, sir. Yeah, there are a few with some with posterior canal, deficiencies and whatnot, but they would, so balance is more complex than hearing. I think if you look at the vestibular pathways, both peripheral and central and proprioceptive and visual inputs that they have, whereas with hearing it's only the labyrinths giving it. With balance we have so many compensatory mechanisms.
Yes.
I think it's a more complex and more
Yes.
balanced system, more evolved system than hearing is.
Yes. May I ask Dr. Vishnu for his question, please?
Hello. Good morning, sir.
Morning, Vishnu.
Sir, I am Dr. Vishnu. I am from Ernakulam. I am third year postgraduate, sir. My question is indication for cochlear implantation and auditory brainstem implantation in neurofibromatosis type 2.
Specifically in NF2, how would I decide whether this patient will do well with a cochlear implant or do we need to look at auditory brainstem implant? Now, do you want to take that? Because I think it's a very electrophysiological kind of decision making, and we've done some work on similar situations. I think I will get Puru Kumar to answer this question.
So in the NF2 case now, for us to come with a suitable management plan, it could be the idea of how it's going to be handled. Now, if it's going to be a scenario where the hearing part is going to be completely compromised or the nerve is going to be compromised to get the managerial options, then we've left out with considering a possibility of an ABI. The thing with the ABA also, it might require long-term management and also a lot of counseling to the in terms of the expectations that they would want to have. However, if the possibility of if the size is small and then it's going to be planned that it's going to be considering options to be shrunken, or it's going to be left like that because of the size being too small, then the possibility of a cochlear implant can be considered in such a scenario, provided the family understands that if things gets worse, then the implant may not be beneficial. And then later on, the cochlear implant may have to be removed and the possibility of an ABI will come back. So as you can see that there may not be a hard and fast rule of one particular option that suits all. It's possibly a team decision that we'll have to make considering the given scenario of each individual patient and the team approach and looking at probably working closely with the radiologist as well. It would be a key consideration in choosing this option. One of the other things that we've done also in the past is to run a EABR to check in these patients if we are going to get a consistent response and possibly consider a cochlear implant in that particular year if we are able to get a good response. Hope that answers your question.
Wonderful. Dr. Sunil, one of our cases failed. That was because this patient had an auditory central processing disorder, which we failed to understand and clarify. So the amount of distraught, how the patient, family, we, and they made a lot of noise and all that thing happened. Auditory central processing disorder and all this happened. We implanted and failed. What is your take on this, Dr. Sunil?
CAPD.
Yeah.
Oh. Again, that's an audiology question. I mean, I can take a ANSD question, auditory, the auditory neuropathy spectrum disorder. So ANSD, pediatric ANSD patients, the so-called primary ANSD patients do very well with cochlear implants. But acquired ANSD, they don't do well at all. So the results are very variable. These are patients who have not done well with hearing aids also. So ANSD is one component. CAPD is another one altogether. CAPD, I think, is a difficult one to handle for anybody, sir. Including.
But Dr. Sunil, we are in God's own country where people suddenly become violent. And how do you upfront before implanting understand that, listen, don't touch this patient? We never did that, and we landed up in a mess.
Yeah. So we have, and Purva touched upon that, we have a battery of audiological tests and electrophysiological tests that may give us pointers here, including something called, and we have published on this, both of us. I don't know if you've seen that in the IJOHNS, called Trans-Tympanic Electrically Evoked Auditory Brainstem Response. So TTABR for short, where you have a golf club electrode which you put with a tiny myringotomy, postero-inferior quadrant myringotomy. And I would, as a surgeon, hold the electrode just under the operculum towards the round window membrane. So this is like an extra cochlear electrode. And then that is connected to an implant in the box. And then Apurva would stimulate the cochlea. And then we are looking for a wave 5 or wave 3 and wave 5 response in response to this electrical stimulation, albeit extracochlear. So if you get a robust response, so we've got what is called the Kumar Dutt classification. I'll share this paper with you, sir, uh, where we have classified it into type A, type B, type C, and type D. And in short, a very good, robust wave 5 morphology would be a type A. A good response may not be as robust as type B. A fair response is type C, and a poor response or no response is type D. So if you got that in all these patients, and you got a C or D, you can upfront tell them, we don't know if a CI would work for you. We can do it because there's probably no other option available. You've tried everything else, but we don't know if this will work for you. So there's a guarded prognosis attached to these type C's and type D's. Type A and type B, all of those that we have tested and got type A and type B have done extremely well with cochlear implants. So you want to elaborate on that, Pura, and all the other tests, like your LLRs and ASSRs.
So, like Dr. Dutt mentioned, looking at multiple tests or the test battery approach was going to be a really key factor. And as he touched upon, there are a couple of extra tests which we'll include in the battery, including the transtympanic EAVR. The other test which we also run before we consider for the transtympanic EAVR is the LLR or the CAEPs. So in case if we are going to get responses on these LLRs or the CAEP tests, or if we are able to pick some responses, it's a good indicator for us saying that centrally there is some summation or the responses are happening, which means that we can consider that particular site to try and confidently say that we may get definitely some kind of a response on that particular site. And in order to make year specific decision, that means, for example, in our country, if it's going to be only 1 year that's going to be implanted, or if we are going to consider single or unilateral implantation because of the cost or other factors, then we will probably run transtympanic EAVR also in certain patients, because it's going to be an electrically stimulable device, the cochlear implant system. So the TTAVR is also an electrically similar type of stimulus that's being used. So based on the electrical stimulation, if we are going to see a discrepancy between the two sides, the side with better responses, morphology and latency is the one that we're going to pick in case of a unilateral implantation. So adding these tests gives us additional information on saying, yes, we can consider that side and probably we'll definitely get some hearing responses. And two, if we have to make year-based choice or a year decision, then the side where we're getting better looking responses between the two is probably considered to go ahead for an implantation.
No, yeah, the thing is, all that is possible only with you and Dr. Dutt. With us, all that we have is a BERA and an autoacoustic emission. And the sudden, when a dozen people barge into your room asking why it has failed, it is very difficult for us to handle, which is why I wash my hands off cochlear implants altogether. Because I was not at this stage in my life willing to take on such risks.
Sure. I think if you have the BERA equipment, then most of them support the LLRs or the CAEPs. Otherwise, some of the BERA equipment will require an additional module to be purchased to run that test with the existing equipment. So that's one of the things that can be considered.
Yeah, but you're surprised, sir. The BERA equipment that we had bought, I wasn't aware was we had already bought it had the LLR module also. It also had the WEMP module, CWEMP module. So sometimes you don't know it's already there in one of your equipments in the various departments there. So I think you should check with your ASLPs. Some of them are here, you're saying. Whether they already have it, you don't have to invest It's just that they have to run the full battery in some of
Yeah.
these patients, not all.
Yes, yes, yes. Wonderful. May I ask Dr. Aisha to tell your question, please? Dr. Aisha. Dr. Aisha, are you there? I'll go on to Dr. Panchami.
Yeah.
Good morning, sir. This is second year PG. My question is, what will speak sound to a cochlear implant patient?
Well, say that again. How does it sound? What
What will
of
Yes,
an cochlear implant to the patient? So I think that's a question everybody asks, and most parents ask for the child. For the child, the simple answer is we don't know, because the child does not have a auditory memory. You're born deaf. You don't have auditory memory. What you hear from the electrode is what you hear for the first time. So I don't think the child would have major issues with that, because there's a very slow, very gradual learning process from the day of switch on right up to speech and language development. But what we know is from post-lingually deaf, adolescents and adults, because they already have an auditory memory. They've heard before, so they know already what normal hearing is and how that sounds. Compared to that, the sound, especially at the time of switch on, they say is probably a little robotic, like a metallic or tinny kind of sound. Piano, what also Apurva will tell you more, because he's the one doing all the switch ons for me. But then I have noticed that that also keeps changing for them as and when the frequency adjustments and the distribution has been made by the audiologist. That's called a mapping process. You've heard of mapping. So they do these, what's that mapping? Meaningful auditory percept is something that at least the surgeons keep saying what a map is. Audiologists don't say that. But basically, you're trying to see what frequencies to give at what electrode. So let's say you have a 12 or a 22 channel or a 16 channel or a 20 channel electrode. What channels will take what frequencies will also decide how the final sound will sound for the patient. And that again evolves from switch on to 6 months to a year to 2 years to 3 years. I'll get Apurva to say a little more about it.
Yeah, so as Dr. Dutt mentioned, different postlinguals say different kinds of expression, especially at the time of switch on. It's primarily dependent on on their auditory memory, on how and the gap that they've been had from the time they lost their hearing and they get the cochlear implant. So they can try to relate with their memory from the previous way how they heard acoustically. And many of them say it's robotic. Some say it's like how the toys which those toys which can sing happy birthday to you kind of a thing. They say it is probably a little robotic. Some say it sounds like a waterfall. Some say it's like the music is playing, or different kinds of a piano keyboard is being played. That kind of an expression it's nothing something that's consistently same across different patients, each of them based on their previous experience in the memory of their acoustical hearing. They're going to give that information. But over time, as the reorganization that happens with electrical hearing, the auditory reorganization with what we call during the acclimatization period, which can vary between from the first week since switch on can go up to something like 3 months. And then the same patients who in the beginning said it is like a keyboard or like the piano or the robotic kind, slowly say it's becoming a lot more normal, because the system is adapting to this type of hearing. But even after many years, they will say it is different from the acoustical hearing they had. Not exactly the same, but they feel it's become as good as very natural to hear. That's primarily because they got used to it over the years or over the weeks in the first 3 to 4 months.
Thank you.
Yeah, wonderful. May I ask Dr. Anushri with your question, please?
Good morning, sir. This is Anushri, second year postgraduate, sir. So my question is, what are the recent advances in cochlear implant surgery, sir?
Yeah, we touched upon some of these. And there are plenty of advances in from the from the microphone till the tip of the electrode. You know, the different parts of the implant, external and internal components. So starting from the microphone, the various attachments to the speech processor itself, the transmitter coil, yeah, the physics of it, the well, various things, the components, and then the inside receiver stimulator package to the electrode design till right up to the tip. There are different advances. Very briefly, uh, as far as the electrode is concerned, I'll leave the external parts to you. Uh, I can leave everything to you, but the electrode, I told you already, we are looking at atraumatic electrodes, preservation of residual hearing, something called electroacoustic stimulation. Have you heard of that? EAS. EAS is electroacoustic stimulation, where if the residual low frequency hearing is good with the patient, you would want to give them just a hearing aid option for that component, and the rest of it will be an electrical stimulation. So you have both acoustic stimulation, albeit amplified, and electrical stimulation for the rest of the frequencies for the patient to benefit. So that's called electroacoustic stimulation. Some companies call it hybrid electrodes. So I think that is a pretty recent advance, and that's been happening a lot abroad, not so much in this country, because the majority of our patients have profound deafness and not much residual hearing. So that's one. And we're looking at, I touched upon this already, drug eluting electrodes, where various things have been tried. You know, I talked about neural growth factors. We're looking at some of those immunogenic factors, steroid eluting electrodes, quite a few, um, uh, gap junction protein related ones, hair cell regeneration ones, and various things. You know, genetics have been looked at. Cell research is also based out of drug delivery, including an electrode into the cochlea. So various things have happened with that. Yeah, so at tiny, slim electrodes, shorter electrodes, you know, there's something called a sweet point. So the sweet point now we are understanding is about 23, 24 millimeters into the cochlea. May not be beyond, and too less is not also not good. Too much, too deep is also not good, is what we are slowly learning. So that sort of thing, making it slimmer and thinner, making it mid-scalar rather than perimodular or lateral wall electrodes. Lot of advances are happening, a lot of R&D with these. And as far as the externals are concerned, you know, you're getting rid of everything, putting everything into one unit. You know, like the Cansos and the Rondos that we have, uh, the ear processors. So the processor has the magnet. There's no, so it's just the coil with the magnet and the microphone and everything within it. So there's nothing going behind the ear. There are cables attached to it. That sort of thing has happened. There's miniaturization of both the receiver stimulator package and the external components. They're getting smaller and smaller, understandably so. Then there is better acceptability. And there is still research going on with a totally implantable cochlear implant. Totally implantable cochlear implant. So that's called Tiki. That research is going on in a few centers across. So it's quite a lot.
Wonderful, Dr. Dutt. I stumbled on the University of Washington Department of ENT where they showed regeneration of hair cells by 13-cis retinoic acid. Now, apart from that, I stumbled on a news item. Dr. Pandit from Mumbai did some work in Australia by stem cells and got the hair cell to regenerate. I called her to my department and then she gave a wonderful talk on the work she had done. But in between, I will ask my postgraduate who's doing some work on medical recovery of hearing. May I ask that PG to briefly highlight what is her discovery.
Do you have a name for the
Yeah, Dr. Anushri, or who's that on recovery of hearing by drugs? What is our work and how much have we progressed? But in the meanwhile, I must highlight to you my classmate who is doing work based on neuroplasticity. If the Broca's area is defunct, he rewires the brain. So born blind children, the sight receptive area in the brain has been rewired and they have got their eyesight back. It's a tremendous miracle which is unfolding at the Amrita pediatric section in Ernakulam. Now, of course, he is relocated to Guwahati. You know, fantastic work on rewiring of based on neuroplasticity, and I was amazed at the work that he was doing. But before we come to that postgraduate, we will now talk about. May I ask Dr. Aisha to formulate a question, please? If Aisha is not there, can Anushri highlight what the question was? Anushri, are you there?
Anushri spoke before, no?
Anushri, what was Aisha's question? We can't see you, Anushri. Yes.
Hello, sir. This question is regarding Dr. Aisha's question. How do you investigate cochlear nerve or auditory nerve before cochlear implant surgery? Like, how do you investigate for functioning of cochlea and auditory nerve before choosing the type of implants?
Yeah, did we not cover that? I think we covered the fact that there is this whole battery of tests.
Yes.
Audiological and electrophysiological testing, so to speak, both subjective and objective.
Yes,
and
Anushri,
radiology also, and I think radiology will strongly guide us. Again, that was touched upon as to what kind of electrode we would need, depending on the malformations, depending on the duct length you use. If you think you want to introduce a 31.5 millimeter long electrode, one of the companies that electrode, right?
Yes.
The helicotrema, you need to measure that so much is available. So I would say, because it's already touched upon that very briefly,
yes.
We have both audiological and radiological candidacy criteria that we look at and study them in detail before we decide on what electrode and.
Yes. Anushri, who's that who's doing on hearing recovery by drugs? Methylcobalamin and docohexanoic acid.
Aisha is doing that thesis work.
Yeah, is she there now? Just call on her and ask her to talk about her work.
Yes, sir.
A little
Yes,
later, down the lane.
Yes,
May I ask Dr. Abhinandan, your question, please?
Good morning, sir. I am Abhinandan, first year postgraduate, sir. I am from Mangalore, sir. My question is, which is better, sir, middle ear implant or cochlear implant for hearing, sir? Hearing improvement.
Yeah, so there are different indications, Abhinandan, for middle ear implants, bone conduction implants, and cochlear implants, and auditory brainstem implants. So if you look at implantation otology, we have implants for that work with just bone conduction physiology. So there are bone conduction implants like bone anchored hearing aids, bone bridge, more recently the Ossia, and a few others, Sophono and whatnot. Then there are cochlear implants. Then there are middle ear implantable hearing devices, plenty of them, but But there is the vibrant sound bridge you probably heard of. There's Envoy's team that was there some time ago, but the company closed down. So there are quite a few middle-ear implantable hearing devices for a different set of audiological and clinical indications, not the same as cochlear implants. Cochlear implants are in general for severe, profound, bilateral cochlear or retrocochlear deafness, so sensory neural deafness. All the other implants have some mixed components to it or pure conductive components to it. So there's no comparison between middle ear implants, bone conduction implants, and cochlear implants. There's some overlap here and there. There are patients with progressive deafness who first did well with some middle ear implants, but eventually had to have cochlear implants. But barring those few, the indications are entirely different for the different things that you're asking.
Okay, thank you.
Who's next?
Yeah, Dr. Sunil, the difference as a person, difference between air and bone is hardly 5 to 10 dB maybe. But you would have seen the Bose spectacle hearing device. I wonder why no hearing aid company has come out with a spectacle, because it is very easy for me to say you need to wear glasses. Immediately it is accepted. When I say that you need to wear a hearing device, there's so much of reluctance. Would you have any idea whether is anything in the offing that will be so wonderful that some ENT surgeon would have had the innovative idea to bring out such a device?
Well, it's more an audiology domain than ENT, right? So I'll leave
Yeah,
it
if
to,
you
yeah.
Yeah, if you've seen that Bose hearing thing, it is, and even the Google Glass for that matter, it just touches on the master and the hearing is so good. Slight, they increase it by about 10 dB and it overcomes the air conduction. I wonder why nobody has thought about coming out with the glasses of that caliber.
Yeah, so the previous bone conduction devices which employed the idea of using the frames had to be thicker and at the back, and had to get an interface which needs to be.
Yes, I saw, but that is so bulky and massive. But if you see the Bose hearing spectacle, or if you've
Right.
seen the gold glasses, it's a tiny little thing, but it's so fantastic. I wonder why nobody has thought about. Maybe you should set up an industry of your own.
Yes, I think the technology is now coming there to make miniaturized and have bone conduction devices, and also there are plenty of bone conduction headsets that are now seemingly becoming popular and more affordable and usable by a lot of people. And it's now regular earphone type of bone conduction principles have been easily available in the market. So I think it's a matter of time where that can be optimized for hearing, where a larger amount of gain is required for somebody with a bit of a hearing loss than the gain,
Yes.
and to manage the feedback. That's the leakage from the microphone that needs to be handled with a little bit of technology that would be needed. And I don't think it should be seemingly too difficult, and it's not too far away to be commercially available in a much more compact form factor and more acceptable with interchangeable frames. It would be just be a connectable to their existing frame, or a slottable for their existing frame, which
I
can.
hope it happens as quickly, because of the advantage.
Yes,
Aisha,
it should be
Aisha,
soon.
if you're there, can you please tell us your work? Dr. Aisha, please.
Good morning, sir. My thesis topic is the combined effect of methylcobalamin and omega-3 fatty acids on sensory neural hearing loss.
Yeah, so tell us about your inclusion criteria.
My inclusion criteria involves mostly a patient between the age of 20 to 60 years, sir, and the patients with no comorbidities like diabetes, mellitus, hypertension, because that could also affect the sensory neural hearing loss. I'm mostly evaluating for the age-related sensory neural hearing loss and the effect of omega-3 fatty acids and methylcobalamin on that.
What is your results, Aisha?
No, so hold on. It's not for sudden SNHL. You're looking at progressive presbyacusis kind of patients. Yeah.
Yes, sir. Yes, sir.
Okay. Okay. And what have you seen so far?
So far, I've evaluated around 30 patients, 30 to 40, and it has been slow because of the COVID. So after that, few of the patients have come back for follow-up. I do a 3 months follow-up. So we repeat PT after 3 months. I've seen that there has been a little bit of improvement around 5 to 10 decibels in few of the patients, like around 15 patients. And few other patients have given placebo, that is calcium supplements instead of methylcobalamin and omega-3 fatty acid. So in them, we haven't seen much improvement. Like it's been around 2 decibels or even lesser, like they've progressed to more hearing loss.
Worsen. Yeah. That's interesting.
Worsen, yes.
Yeah, Dr. Dutt, I have had 2 patients advised cochlear implants, given these drugs, absolute recovery, and they have foregone the implant. Primarily, they came because they could not afford it. I have had innumerable patients, especially presbyacutics, 100% relief. Just these 2 combinations, methylcobalamin, docohexanoic acid. So that's an area perhaps we should explore a bit more, perhaps.
Absolutely. Yeah. I think,
May I ask?
I just want to add a line there that with progressive hearing loss, I think there's a lot that can be looked at in terms of medical management and reversibility of that kind of loss, which I don't think research has really been done in those areas. And I think a few of you in this country and abroad are looking at that, and I'm very happy you're looking.
Thank you. May I ask Dr. Rinshin, your question, please?
Good morning, sir. I'm Rinch.
Your voice is not clear.
Not a good connection.
He has forwarded his question. May I highlight it, Dr. Sunil?
Why not, sir?
He says, at what age can we do cochlear implant in a child? What is the candidacy criteria?
Yeah. So candidacy again, we've discussed, but in general, if you're looking at children, congenital, the profound hearing loss is the general population for cochlear implantation that we are looking at, who have not benefited with hearing aids. Not for you to arrive at that kind of a diagnosis, audiologically speaking, would take anywhere from 5 6 months to about 9 months, to confidently say behaviorally, audiologically, electrophysiologically, just this child is profoundly deaf on both sides and not be benefiting with hearing aids, because so you would have done a hearing aid a month or 2 months or 3 months also, unless logically there's evidence that there are malformations. So barring those, you would otherwise try a hearing aid on both sides, in fact, and look at therapy for the child before you embark on a cochlear implant journey. So that would happen roughly around 9 months to a year in this country. That is only if you're extremely enthusiastic about it. So we have something called the 1-3-6 rule, and I'm sure you're aware of that. That's something we ask in MS and DNB exams also, because that's something that we are trying to achieve here also. The West does. 1, as in as soon as you're born. 0, in fact. As soon as you're born, you should have a detection of hearing loss. 3 is when you diagnose hearing loss. That is 3 months post birth. And then 6 months you should have intervened also. So detection, diagnosis, and intervention at 1, 3, and 6 months post birth is what we are trying to achieve. If you intervene by 6 months and given a couple of months of hearing aid trial, it's not working. Behaviorally also the child is not doing much. You are then considering the child for a cochlear implant. Now, In the West, they have implanted younger than that age. Also, they have implanted at 6 months and 4 months. The youngest I have implanted was a 7-month-old for post-meningitic deafness. The post-meningitic deafness, as we told you, with ossification, is an emergency indication, or I would call it an emergency indication for cochlear implantation, because you don't want to lose the lumen and you want to get the electrode in before the lumen completely closes. So, but for that, we would otherwise wait for about 9 months to roughly a year, confidently everybody involved telling you, including your audiologist and the therapist, telling you this child is not benefiting with the hearing aid. I think we should proceed towards a cochlear. Correct?
Wonderful. Dr. Sunil, you stand at the forefront of the cochlear implant scenario of India. And it is so sometimes tragic when we see children who have been neglected and go into the post-lingual area. Maybe perhaps, the MCA should say that all pediatricians and ENT surgeons at least once a year should have an orientation by you or similarly, so that at least there's awareness that do not neglect these children, quickly go inside, because once they cross the 3-year limit, it's a point of no return. And it's so sad sometimes when you see these children.
Absolutely. Absolutely. And early.
Can I ask?
Yeah, I just want to add that early implantation has good given results, almost as good as normal peers. If you implant a 1-year-old or even a 1.5-year-old, the speech and language outcomes that you get with that child, especially if you did a bilateral implant, are similar to a normal hearing peer. Sometimes they do even better than the normal hearing peers. So the earlier you get in there, the better for these children.
Born deaf, dumb children whom we have implanted, beyond in a few years down the line, they are now non-stop chatterboxes. And it is when we see that, it's a divine blessing that God has helped us, recover these terrible, unfortunate children to secure back into normal life.
Absolutely. Absolutely. Yeah.
Dr. Pujit, are you there?
Sir. Sir.
Good morning, sir. Yes, sir.
Yeah.
Good morning, sir. I'm Pujita, first year postgraduate ENT. So my question is robotic surgery being used for cochlear implants? If not yet, is there any future regarding that, sir?
So we are considering it. There are a few clinical trials, to speak, happening. First, it happened with temporal bones, got these fiducial markers, and then how the robot armed with the drill could go in and go through the facial recess and get to the cochlea into the scalar tympani. That is happening. The research is still going on. We need to get it right. So there's and radiology had to improve also, because only the radiology planner could guide the robot to get in that trajectory. You have to get the correct trajectory for it. So a few companies are looking at it, and mostly I think in Europe, France, Netherlands, and probably Switzerland, if I'm not mistaken. Some of these friends of ours, the surgeons, have tried that as clinical trials, and they work. But you just have to get the trajectory right. Okay. So it's like a combination of the Varia technique with the posterior tympanotomy technique, where you just have to get that single line pathway from outside right up to the cochlea without disturbing the structure around. That includes the facial nerve and the chorda tympani. And so it's happening. It will definitely come. It will probably come in different forms. And I think definitely while you get out, you're in your first year. So my prediction is in about 5 years' time, we will be doing a bit of robotic surgery.
Dr. Sunil, the great problem now is the paucity of temporal bones. I gave a letter to a postgraduate of mine in Melbourne University. Somehow it clicked, and he's now doing his PhD in virtual temporal bone with haptic touch. He says it is so realistic that you actually almost feel like as if you're operating on a real temporal bone. Any
Yeah.
experience or exposure or thoughts on that?
Yeah.
Virtual temporal bone dissections.
Melbourne, you talk about Melbourne. I've been there a couple of times, and there are some very dear friends there, Rob Ricks and Stephen O'Leary. Stephen O'Leary, in fact, has been working on this for quite a while. The simulations, the virtual simulations
Yeah.
of the temporal bone, and I'm sure your juniors working with him because he's the one who's very excited about this kind of work. It's already happening with laparoscopic trainings. You know that, right? For general surgeons and GI surgeons. So that's something that is being strongly promoted by quite a few Western countries, including down under. And it will come. It will definitely come. I think eventually we will get into that mode of training, the virtual mode of training with 3D models and whatnot, with simulations of malformations and everything else, color coded for nerves, vessels, and the bone and soft tissue. So I think that will definitely come, and that will be an exciting way of training. Yes.
Wonderful. I had no clue, but he sent me a couple of videos on this virtual haptic touch, and it was so fascinating to see all that.
That's right.
May I ask Dr. Chitra?
Thank you, sir.
Dr. Chitra. Thank you, Pujita. Dr. Chitra.
Good morning, sir. I'm Dr. Chitra, first year PG. My question is auditory training essential post middle ear or cochlear implant, and why?
Yeah.
We can't
So
see you, Dr. Chitra.
The answer to that is yes, but I will ask Apurva Kumar to give you the answer.
Yeah, hi. Thanks for that question. Yes, it's required for pretty much any type of the implant system that's going to be put in for the patient, because it's going to be a new learning experience, and the acclimatization period to different kinds of sounds would require some help. It's a good few weeks they will require to get the hang of it, and it is for some children it will be an ongoing process along with speech and language stimulation. So it's required together in hand to work on the skills. Yes.
Thank you.
Dr. Sunil, one case that we implanted, later he had some ear problem, went to a DLO guy. I mean, not that I demean, and he saw a small wire or something and put his forceps inside the ear and pulled it out. What a tragedy.
Yeah.
Any experiences like that, Dr. Sunil?
Well, not personally, but yeah, I've heard of this, and it can happen because see, we thin the posterior canal wall to almost like a paper thin bone china thin thickness. And also with the other technique, the Varia technique, also the Varia tunnel is very close to the posterior canal wall. So there's a degree of dehiscence that's possible there. Well, theoretically speaking, but it's happened, with some patients across the world. Although newborn formation is the norm, and the newborn should take care of all this. So if someone very over enthusiastically tries to clean a keratotic, wax and debris in the ear canal, you may be peeling off the covering over that excess lead, the electrode lead, and I have heard of this happening. So the important message here is never allow someone else to look after these patients, especially cleaning their ear canals and whatnot. I think it should be one of your own team doing it. But should the patient shift to another place, which they will, you should make sure that you hand them over to someone who you really know, regardless of their qualifications, but you should be confident of their skills and training. So if it's another CI program, it's well and good. But even if it's a good otologist, someone with good skills, I don't think there is an issue. But it's unfortunate. I've heard of these stories across the.
Well, perhaps, no, he came from Ernakulam just for the implant to Mangalore, and then he went back doing pretty well. But then this tragedy happened. Maybe we should have given an aluminum or a solid card, like a visiting card. I am an implantee, and show that to any doctor. Like we give this allergy. This patient is allergic to so that we are very careful on how we handle them.
Yeah.
Maybe that's where lapse we had. We did not give him a card saying so.
They do have an implant card, right? Each company gives within that box.
Yeah.
An implant registration card and an implant card which they carry, especially when they're traveling, right?
Yes.
They always carry that. Maybe this patient didn't want
No,
the.
this is a company of the website was I Enjoy Sound. That particular company, I Enjoy Sound. But because why were we forced to take them on? Because they were much cheaper than what is currently available.
Fair enough.
And as a consequence, that's the terrible tragedy that happened. May I ask Dr. Rohan to come on, please? Dr. Rohan.
Good morning, sir.
Yes, Rohan.
Morning, Rohan.
Dr. Rohan. Question is, following the cochlear implant surgery in a child at a very young age, is there any chance that the child may outgrow the cochlear implant, thereby requiring furthermore surgery?
Very good question. So,
Wonderful, yes.
So the point is one implant enough for a lifetime? So I'm just rephrasing your question. So is a single implant enough for a lifetime? The answer to that is yes. And that is what is told to all patients, because as far as the companies are concerned and the research and development is concerned, one implant should last a lifetime, as in at least the internal components. The externals also, if you look after it well. But then there are upgrade possibilities, newer technology coming, so you will keep changing the external components. So the longest one person has worn an internal implant, the same implant, without any failure or device failure or a requirement of reimplantation, is 40 years, close to 40 years. Holly McDonald, right? In Sydney or Melbourne in Australia. She was the first pediatric implantee, and she's still using the same implant near to 40 years now internally. External, of course, she's taken upgrades of whatever is available from that company. So the answer to that question is yes, one implant should last a lifetime, and that's what all the R&D is doing. But then, as CI professionals, the audiologists, the therapists, everybody who's counseling should tell parents, especially for a child, may not be so much for a postlingually deaf person, adult, but for a child, you should say that it is meant to last a lifetime, but it is possible that 15 years, 20 years, or 30 years down the line, it may fail and he or she may need a new implant. I think your consent form should include that the implants are meant to last a lifetime, but a device failure is possible. So each company puts up its failure rates. It's called CSR, cumulative survival rates. The companies on their websites have already put them up. So the CSR may be 99.2% or 98.3%. So which means for every 100, 98.3 of them work, the others have failed in various periods. So your consent form will say that this implant is meant to last a lifetime, but it is possible that the device may fail this percent, and the child may need reimplantation in some time in the future. I think you should cover yourself by saying so.
Beautiful. I did ask.
Thank you so much, sir.
Thank you. I did 2 or 3 stem cell centers in Delhi, because they are doing some stem cells thing in liver, in kidney, and other things. I said I will give the backup from a medical college to this viral vector injection into the middle ear and do some work, but all of them politely declined. Any idea whether anybody has done any stem cell work and been able to get the hearing back, Dr. Sunil? That will completely change the field of hearing, perhaps, for good.
Yeah. Well, so like I said, it's definitely happening abroad. I don't know them personally, but both in Europe and the US, there is stem cell research happening. Dr. Ravi Nair himself was interested in it, but I don't see him on the live here. But he was interested in it in St. John's. There is a research center in St. John's that he was trying to see if he can start that kind of work. But I'm not too sure if anybody in India is working on stem cell for hair cell or spiral ganglion cell related research. Yeah.
Dr. Sunil, this has been an extensive coverage on cochlear implants. What a fantastic opportunity my postgraduates have got. It is a divine blessing for them, for you to spare your precious time and spend with us nearly 1.5 hours today morning. And why did you consent? That is the value of friendship. We've been sort of meeting here and there, and my appreciation right from the days that you were authoring that particular page and how
lost him.
Fantastic opportunities in UK, in Canada, in Australia, but you choose to sort of come back to India and save miserable children. We must appreciate your thank you so much for all your time and words and knowledge. And thank you to the audiologist. Very poor memory.
Apurva Kumar, yeah.
Apurva, you've been a fantastic resource person. I hope if there are audiologists here and if they would like to ask him anything, of course, I lay the field open. I don't know whether they are still on the forum, but Rashmi,
thank you.
Is she there? If anybody in audiology is there, if you would like to interact with Apurva, he is a brain by himself. And it is kind of Dr. Sunil to bring him on the forum because we don't get this sort of interaction with people directly.
Thank
so,
you.
Dr. Sunil, would you like to encapsulate the whole morning session in a few words? And if there are postgraduates who want to pursue a career in implantology, what is your advice to them? Now, I will tell you my outlook because of the terrible tragedies that have happened, failed implants, this thing happening and all that. You got to take a very clear decision. That is why William Shakespeare said to be or not to be, because once you take that decision, it's a point of no return. You got to absolutely focus your life because one implanted child is going to be there with you for life. So it's like rhinoplasty or voice or skull base. You can't be doing everything. You got to really focus. And who's my role model from the very beginning is my good friend Sandra Disa. What a towering lady she was. Yeah. Now, we have got a head of audiology, Rashmi. Rashmi, would you like to ask Dr. Dutt? This is a fantastic opportunity, Rashmi.
Hello, sir.
Heads, Dr. Sunil heads our audiology college. It's actually a college, large intake, and she has taken it to the next level and made it a towering force in Mangalore to reckon with. Rashmi, Dr. Sunil is there listening to you.
And
Thank you,
Apurva.
sir.
Yes.
Hello, sir.
Hi.
Hi, Apurva.
Hi.
Sir, wonderful presentation, sir.
Thank you.
And I think Apurva has covered almost every aspect of it in a very wonderful, very nice way, sir.
Thank you. Thank you very much. Thank you for listening. Yeah. Well, we didn't present. It was a wonderful interaction, and thanks to all those questions from
interaction. That's correct.
Yeah, from all the PGs, and I think
yes,
even has put those the minds to test, so to speak. The inquisitive minds and the research oriented minds. I think I'm very pleased to hear from all of them, about a dozen of them.
And one of our students were also there, sir, so they also definitely benefited.
Yes. Delighted.
Thank you so much for all the efforts and
Dr. Rashmi, one thing very clear, I have washed my hands off. It is not my field anymore. But then if my faculty, somebody takes on the implant field, maybe you will be there at the helm to sort of take it forward with Dr. Sunil's guidance and
definitely, sir. Looking forward, sir.
Perhaps in time to come, have a major cochlear implant center in
yes, sir, definitely, sir.
Yeah, so like I was saying right up front, you want to make some concluding remarks, sir.
Yes, Dr.
I would say is yes, focus is very important, and I think that's what I have done, and I've focused on implantation otology. Not that I don't do other things, we are all, to begin with, general ENT surgeons with a focus. It's the same with the head and neck oncology surgeon, with a rhinologist, with the laryngology and voice specialist. So I think focus is very important. It's something you can work on just after your MS. Maybe in the first year of your senior residency, you try and see what excites you the most, what you get passionate about, and you want to serve the community. And like Sir clearly said, uh, this is a commitment for life, not the child's life, your life, because these kids will outlive you. So for the rest of your life, you have to look after these children. They become your extended families. And then you also need to have a succession plan, because someone asked about reimplantation later. So in 30 years from now, some of these devices that you have implanted today fail, your successors should be able to handle that for you. So I think you are looking at a very long-term plan and a succession plan, a center that continues to serve these children for the rest of their lives. So I think that is something that you have to plan ahead. And like I said, candidacy in India is humongous. There are about 3 million children waiting to be implanted. We are talking about under fours and under threes, leave alone the others. And and the incidence is very, prevalence is very high. We have done only about 40,000 implants in 3 decades across the country, starting from Sandra ma'am's first surgery. So I think there are plenty more to be supported, and the support is not just doing the surgery. Surgery is just one cross-sectional intervention. Post that we discussed today, there's so much to do with these children. You have to look after them, handhold them and their families, get them into mainstream schooling, get them into professional lives, and help them succeed in their professional lives. I think if you make a passionate attempt at focusing on this and working towards that, it is extremely gratifying. And I have
Well,
been.
in that regard, what is the most defining moment in a cochlear implant surgeon's life when you do the switch on? And for the first time, the child hears, everybody in the room will start crying.
Absolutely. Absolutely. You're so right. That is a defining moment.
Yes, absolutely.
That is when we realize life is worth living.
Yes, sir. Yes, sir. So that's my, advice to your PGs. And there are fellowships available. There are plenty of, we also have a RGUHS recognized implantation otology fellowship here in Apollo. There are fellowships available across the country and abroad too, like the one I had done in Toronto. So if any of you are interested, I did do a webinar on that with the DNB Mentors program. Maybe that's available online. If you can get hold of this guy, Sriharsha Tika, you probably heard of him. And I think it's available on that website. Done a few other webinars too. I could send those links to you.
Dr. Sunil, if any of my postgraduates want to do a fellowship under you, they are welcome to approach you, isn't
Absolutely, absolutely.
And,
we do
and
an interview
all
around, sir, July. I think we do an interview for a September program. It's an fellowship. Post MS or DNB is the requirement. That's all it is. Yeah.
I hope as the years unfold, or months rather, that you would be a regular visiting faculty in presence, not just on a virtual, because I know how magnetic and charming you are.
I would love to come, sir. I would love to come and support your program.
It's been a wonderful morning. Thank you so much, Dr. Sunil. Until we catch up next time, thank you so very much. Talk to Dr.
Excuse me, sir.
Yeah. Somebody
Sir,
from
I have a doubt.
We can't see you, please.
Audiologist.
Yeah, I'm audio.
Yeah, we can't see you, but yeah.
Hi. Good morning, sir. Sir, I'm Ritu. I'm audiologist working in Department of Audiology. So I have a doubt.
Where are you?
So
Where are you based?
Department of Audiology in AJ Institute.
Okay. Dr. Sunil, we have so many faculties coming in that I would not know many of them.
Understand.
Sir, I have a doubt. Like we'll be inserting after cochlear implant surgery,
after insertion, few electrodes will be open and impedance will be more. So during that time, we'll switch off those electrodes. In that case, will the patient miss out some frequency informations if we switch off few electrodes?
Okay, I'll take that question. In case of if we find some open circuits or the sum of the electrodes show very high impedances, we'll switch them off. The frequency allocation is then shifted to the rest of the electrodes. So we won't be missing out significantly on the frequency information. So say in an example, if we have to take three electrodes are showing higher impedance, then if we switch off those three electrodes, the frequency allocation is then shifted to all the remaining electrodes. So we won't be missing out on too much of frequency information.
So if like more electrodes are open, so that time we'll consider for reinsertion, right? Like what is the number of electrodes like we'll consider for reinsertion?
Yeah, so if it's going to be at the intra-op scenario and this is the first type during the surgery, then if we are losing more than 30% of the set of electrodes on the array that's available, that means in the number of channels, like different manufacturers and different electrode array types have different number of channels available. So if you're losing more than 30%, then it's a good idea to consider possibility to go for a backup implant, provided that the likelihood of getting this backup implant without facing similar kind of difficulty is kept in mind. So if we anticipate the second electrode also we're going to go through the similar difficulty, then probably we'll not go for the backup implant and keep sticking with an existing option. But if we are very confident that going for a backup implant will not have the same difficulty and are able to get to the complete insertion and get more electrodes, then definitely we'll go for the second implant or the backup option.
Thank you.
Thank you.
If it's a difficult insertion for the surgeon, so let's say you have a 12 channel electrode. If you can't get more than 8, then you have to consider a new electrode, second implant. Then if you can't get 15 out of 22, 16 out of 22 for the other company, then you're considering a new implant. Then so each and for the 16 channel electrode with AB, at least 11 should be in. So each company has a figure for how many electrodes should be in for them to optimize the frequency distribution. So if you think you have not got so much in, you have to consider the backup. So we'll always have what is called a backup implant available for every surgery, and the backup box there's only once in so many hundreds of 550 implants that we have used, because we had, like you rightly said, very high impedances and which wouldn't come down at all when we were not able to get a NRT on that. So we've changed that only once in so many. So a backup is always advisable to have with you, and all companies recommend that. Okay.
Any a word on the various companies, Dr. Sunil? So many companies, and I will not advise this particular company because the wire, the battery, everything became delayed in supplying, and that is another major hurdle that we faced.
See, the bottom line is, the not wanting to take names because you're recording.
Yeah,
here.
I know.
What I would say is, if this child was one of your own family, what implant give this child is what you have to first ask yourself, isn't it? So if this is one of your own family, you would implant a tried and tested implant, which has 30, 40 years of R&D and has been all regulatory approved, including the US FDA, because US FDA is one of the most stringent regulatories available today. So if it passes all that, that is the implant, and the service in this country after service, getting accessories and everything else is easy for them, and it's a patient-friendly company. I would go ahead and take that implant. The one mentioned did not have that, right, sir? I know that for a fact. And there are a few others too like that. So I wouldn't recommend those companies. I would go for someone who has 30, 40 years of R&D, and they're all about the same level, in my opinion.
Yeah, when did I breathe a sigh of relief? When I crossed the 10-year limit in which I am no more legally culpable.
Yeah.
I said, oh my God, thank God, because all these problems were happening.
Correct.
I don't think my postgraduates could have a better exposure concerning cochlear implant than what they have witnessed this morning. Dr. Sunil, Gu and Ra. Gu means darkness, Ra means light. And when joined together, light always dispels darkness and you become a guru. And you have been a fantastic guru this morning to all my postgraduates and those on the forum. We could not have a better session than this concerning cochlear implant. You are a blessing, Dr. Sunil. Thank you so very much. I'm deeply indebted.
Thank you very much, sir. Very humble, both of us, for having us here. This has been a wonderful interaction for us. Thank you very much.
Thank you. Thank you.
Thank you, sir.
Thank you.